Spirit of Women Gut Check. My name is Liz Mikado. I'm a registered dietitian and Director of Food and Nutrition Services here at Aspirus Riverview Hospital. As always, our refreshments, we try to get them to reflect what the theme is. So today we're eating gut check foods. We're going to start off with cowboy caviar, which is going to be served on whole grain tortilla chips. Cowboy caviar is got a ton of different flavors, and if you look at the colors, when we say eat colors of the rainbow, it sure matches that. It's also a very high fiber appetizer. Fiber is something that the gut needs, and we're pushing it tonight. The next item is stuffed mushrooms. Our stuffed mushrooms are gluten-free. There are a fair amount of individuals that have celiac disease or a wheat allergy, a wheat intolerance. So our gluten-free stuffed mushrooms are going to meet their needs tonight, and everybody gets a taste of how good gluten-free can taste. Then we have our cilantro chicken satay. This is chicken. Chicken is a wonderful protein. It's lean, and this particular dish has no allergens. Then let's move to prune fritters. When you're talking the gut and you're talking good integrity of the gut, we think of prunes. And we thought, how can we get prunes in here in a way that the participants would enjoy them? We came up with this easy recipe, prune fritters. You won't even know it's prunes. For dessert, we have our mock peanut butter cups. These are not made with peanut butter. They're made with sunflower nut flour. Sunflowers have a very distinctive taste. They're allergen-free, they're gluten-free, and they're chocolate, which all women like. Downstairs, we have our fruit yogurt smoothie. Yogurt, we had to include yogurt when you're talking about the gut, and fruit. Fruit is full of phytochemicals, antioxidants, and is good for the digestive system. If you'd like more information on how to increase your fiber in your diet, please give the dietitians at Aspirus Riverview a call and enjoy the program by Dr. Carlson. Thank you.
21st Spirit event. 21st. We've not repeated any of them. Except you did get to see Dr. Torhorst twice. Well, thank you. Thank you for coming back each month. So tonight, as usual, we will have our presentation by our physician, and then afterwards, he will entertain questions. And I would ask you, unless you really need to know about something he's talking about at the moment, to save your questions for the end. Write them down, ask them at the end, because then it doesn't disrupt the program. And oftentimes, the people who are sitting in the front asking questions, the people in the back can't hear it, and it's a little distracting. So if possible, please save your questions for the end. So I would like to, without further ado, introduce you to Dr. Joel Carlson, who is a Minnesota native originally, but he attended undergraduate degree at the University of Miami. So he went from Minnesota to Miami. I asked him why. We have perfectly good schools in the Midwest, I said. And he said it was something about the weather. Yeah. Go figure. And then he thought maybe he'd major in marine biology. But of course we know he didn't do that. Then he came back up to the University of Minnesota, so was a gopher for a while for medical school, and then went way back down. He just goes from one extreme to the other. Went back to the University of Florida, where he was a Gator for medical school, and also did his fellowship in gastroenterology at the University of Florida affiliated hospitals as well. Then he returned, thank goodness, to his Midwest roots. So Dr. Carlson is board certified in both internal medicine and gastroenterology. He's the only fellowship-trained gastroenterologist that we have in this area. Together, he and his wife, Kimberly, have 7 children. His oldest son, go figure, is in medical school. Where? In Florida. And his oldest daughter just got engaged this past weekend. Very nice. The other thing I can tell you about Dr. Carlson and his lovely wife, Kimberly, is that they have 2 really ferocious dogs. And I would walk my big dogs by their house, and these little things that are about a foot tall would come out and scare my big dogs. I think that their bark is probably worse than their bite. So please welcome Dr. Carlson, who quite frankly is one of the nicest physicians I have ever met.
Thank you very much. And it's a pleasure to be here tonight. I want to thank Liz and her staff for a wonderful meal, and I'll try not to tarry too long with the all fiber that's in it. Cannot hear me. Is that better? Okay. So again, I want to thank you for the opportunity to be able to talk to you here, and I want to we'll start out. I thought what we would do is just kind of start at the top of the GI tract and kind of move down and just kind of talk about a few selected topics there. Okay. So tonight's talk is called Gut Check. And what we're talking about here, this is just a little cartoon. Let's see. There we go. Okay, so this is the esophagus coming down, the stomach, and then the upper part of the small intestine is the duodenum. The small bowel is all through here. The small bowel enters the colon down here. This is the appendix, and then this is the ascending colon, transverse colon, descending sigmoid, and rectum. Can everybody hear okay? And hopefully everybody's done eating. So this is just a little cartoon depiction then of the different functions of the GI tract. Obviously, we start by ingesting food, and then we chew it to get it into smaller pieces, swallow down the esophagus, which propels the food into the stomach. It stays there for about a half hour to an hour, and the stomach mixes the contents, grinds them up, and then when they get to be fine pieces, it empties them out through the opening of the pylorus down into the small bowel. That's where all the digestion and absorption goes, and then the liquid then goes into the colon and is solidified. The colon takes water out of the liquid coming down and stores it till a time where it's hopefully convenient for us to pass the stool. Not always. So the first thing I wanted to talk about was reflux disease. It's very common. It's a big part of my practice. And normally at the bottom of the esophagus, there's a circular muscle area called a sphincter, just like the anal sphincter. And that keeps food and gastric contents from splashing up into the esophagus. Sometimes that muscle area doesn't work properly, and then it's easier for acid and other contents to spread and splash up into the esophagus and regurgitate out. And then that then will cause heartburn. One question we get a lot is what is a hial hernia? And a hial hernia is very common. I probably see that about half the time in people that I do upper endoscopies on. So it's very common, and what it is that the part normally where the esophagus and the stomach meet, usually that's above the diaphragm muscle, which is under the lungs. And so if that diaphragm if that area goes up here, then you lose a little pinch of the diaphragm, and then that will increase the chance of having stomach contents reflux up. So it's not the sole cause of reflux, it's a contributor. Generally, if someone has a hiatal hernia, we treat that the same, we treat reflux the same whether there's a hiatal hernia or not, and generally don't do surgery. If people do need to have significant reflux and need surgery, and they have a hiatal hernia, then we'll repair the hiatal hernia at the time of surgery, but the hiatal hernia isn't the sole cause. So typical features of reflux, people know them pretty well: heartburn, water brash sensation or feeling as if things are splashing up and then causing a salivation, regurgitation of foods, and belching. There are some more atypical causes. It can cause by refluxing up into the esophagus. You can cause hoarseness, a cough. It's also felt to potentially exacerbate asthma. We see a lot of people who have chest pain, and after cardiology, etiology has been ruled out, then we're frequently asked to see them whether it could be an esophageal acid problem or other problems. Also, by acid splashing up, that can irritate or it can disrupt the enamel, and you can get erosions. So acid reflux is a very common problem. Things that we get concerned about, symptoms that we would get concerned about, what are called alarm symptoms: if you're having significant pain despite treatment, if there's any problems with the food as you're eating, with it catching and sticking, which could be a sign of stricture. Odynophagia is painful swallowing, if there's unexplained weight loss as well. And this is a picture of a stricture in the distal esophagus, and it's just raw and irritated. This one fortunately doesn't have a food bolus sitting above it, which frequently they do with people. When I first came to town, I probably came in an average of about 2 times a month for people who had swallowed food and it got stuck and didn't go through. And then usually it's with supper, usually it's happened before, so usually it's about 8 or 9 o'clock that they decide to go to the ER. The ER plays with them for a couple hours, so I usually get called at about 11 or 12 at night to go in and take the food out. But I've been here so long that, I mean, there's days where I'll do 3 or 4 dilations in a day, where it's pretty rare for me to have to come in now for a food bolus. It's probably more like once every 2 months or so. Where I trained at, they would just admit them overnight and have them spit in a cup all night, and that was terrible. So that's why I come in at night and take the food out. So there are pharmacologic treatments, and I think we're pretty aware of them. Zantac, Pepcid type medicines that have been around for a long time, the purple pill, Prilosec, and all that. But it's very important, I think, for tonight too, to talk about things non-medical treatment. And so there are certainly things that people can do short of medication or with medication to make it better. And so people generally know alcohol and tomatoey foods and real spicy foods, but also chocolate, coffee, and actually peppermint. I've had a few people that did very well and then started having peppermint candies, and that relaxes the sphincter muscle at the bottom of the esophagus. Smoking can contribute. Being overweight and even not getting back to ideal weight, even just losing 10 or 15 pounds can make a big difference in acid reflux. It's also important not to eat. It's better to eat more frequent small meals instead of large meals, not to have a big meal and then lay down. When you lay down, you want to have an empty stomach, so it's best to not eat for about 2 to 3 hours before laying down. Not have real tight-fitting clothes. And also very helpful is elevating the head of the bed. And some people will use a couple pillows, some people will use a wedge. Really, the best thing to do is to put something on the floor and raise the head of the bed so you have gravity to keep things down into the stomach, or if it does splash up, that'll drain down and not just sit there all night. The stomach makes acid in response to a meal, but it also makes acid in the middle of the night. So about 1 to 3 o'clock in the morning, it's pretty frequent for people to wake up having acid problems. And that elevating the head of the bed can be very helpful. And actually some of the older medicines that we have, the Zantac Pepsid type medicines, actually can work better for that nighttime acid than the newer Prilosec type medicines. There's another disorder of the esophagus that I see occasionally, and it's not an acid-related problem, but it's an allergy, and it's kind of equivalent to people who have asthma. There's an allergen in the air that is inhaled, and then you get inflammation in the small airways, and that causes asthma. There can be people that are allergic to certain types of foods. We'll get to that later. And people who have that, then you get the same type of inflammatory reaction in the esophagus, and that causes a stricturing or a narrowing of the esophagus and troubles with swallowing. And it typically can occur in younger people and men. And it's actually fairly new. When I was training, a while ago, we would see occasionally these esophagus, and I'll show some pictures later, and we kind of we called it feline esophagus because a cat's esophagus has these little ridges, and that was about all that we knew about it. But later on, people found out that they would do biopsies and find out there's these allergy cells, and then it is an allergy reaction, and it's not caused by reflux. So the findings on that can be pretty subtle or very apparent. And I'll get to one. So this is typical appearances. This is called linear furrowing in the esophagus. And there's these furrows here, and then the mucosal rings. And this is why the narrowing here, the food catches there, and this is actually probably chicken, I would imagine, down there. And so this is what a cat's esophagus looks like, and that's why it was called a feline esophagus. The treatment of that, first line is the Prilosec type medicines, because even though it's not primarily caused by acid, about 50% of the time people will respond to those acid suppression medicines. Also used can be the steroids, and it's actually the same type of an inhaler that's used for asthma. It's the same inhaler, but instead of inhaling it, we have people squirt it to the back of the throat, and then you swallow it, and then it goes down into the esophagus and acts topically there. And a 2-week treatment for that for many people can last a long time. We can do endoscopic dilation for it. You have to be a little bit careful because the lining tears much more easily. And at first there was great concern about that, but as long as we're careful and don't be too aggressive about dilations, most people can be dilated up to where they're eating well. And then there are other allergy-type medicines that can be used, leukotriene inhibitors is what they're called, and then dietary changes. And the big foods that are involved in allergies for eosinophilic esophagitis: milk, eggs, wheat, soy, peanuts or tree nuts, and seafood. And in children, a lot of times we'll do testing to find out what they might be allergic to, but they don't always correlate well, and especially in adults it can be really difficult, and there's less of a correlation between avoiding those foods. But in general, milk, eggs, wheat, and soy are oftentimes I'll have people cut back on those to see if that's helpful. So the good news is it's more males than females. And again, exactly what the allergy is isn't known, but again, it's felt to be kind of similar to asthma, only it's occurring in the esophagus. Again, the main problem is with food catching and swallowing. We can usually handle that. There isn't any malignant potential to it as well. So the good news is that the only thing you're allergic to is wood, Mr. Pinocchio. So moving on down, celiac disease. It's really an autoimmune disorder rather than an allergy. It's an autoimmune disorder that is caused by gluten, which is a protein in certain grains, and it is in wheat, rye, barley. Generally not in oats, but a lot of times oats are processed in the same factories and they can get cross-contaminated. And so there are certifications, just kind of like organic food. There's oat certified gluten-free foods. Unfortunately, women are twice as likely as men. And it's a pretty popular thing. And it's a big fad. And I mean, there certainly are people who, celiac disease occurs in about 1 in 130 people. So it's pretty common. I have a lot of patients here with celiac disease. In fact, there's a celiac support group that the hospital has that has been really helpful. So, as I mentioned earlier, the small intestine is it's between the stomach and the large intestine, and the large intestine is the colon. So the small intestine is between the stomach and the colon, and that's where the digestion absorption takes place. The first part is the duodenum. There's a misspell there, but and then the middle part is the jejunum, and the bottom part of the small intestine is the ileum. And so again, if in people who have celiac disease, gluten causes an inflammation in the small intestine, and that inflammation then causes an inability to absorb and digest the foods, and that then causes many of the symptoms of celiac disease. So the most common symptom is diarrhea, gas, bloating. Those are kind of the classic presentation. But there's significant other presentations, and in fact, there can be significant asymptomatic people. So a lot of times we'll diagnose this if people have, anemia, we see a lot of that, osteoporosis, unexplained weight loss, abdominal pain, bloating, and again, a significant portion that are found just because of screening, because of family members or others. But about 20% of people will not have weight loss, they'll be actually obese, and about 10% can have constipation, so it can kind of vary quite a bit. And then the non-classic ones, again, abdominal pain, loose stools, pancreatitis, talked about bone thinning a little bit. You can have vitamin deficiencies, rashes, hair loss. People can have delayed development, children can, learning disabilities, even seizures. And then iron and folate deficiencies. So it can be diagnosed by blood tests are fairly good, about 95% sensitive. To confirm things, usually endoscopy is done, and we'll do an upper endoscopy and do biopsies below the stomach in the duodenum, and those are usually pretty classic, and I'll show you some pictures of that. Also, it can be diagnosed with capsule endoscopy or a pill cam, and that's where it's a little capsule that has a built-in camera, and people come in. We do it as an outpatient over at the clinic. People come in the morning and just have a light meal the day before, light afternoon meal. They don't have to get cleaned up. Come in the morning, ingest the capsule, have a little pack that they wear and go around and do about their daily activities, and then come back at the end of the day. We take the pack off that has all the pictures in it. We donate the camera to the person, and And then I can download the pictures and take a look. So, normally the small intestine has these what are called villi, and so they're finger-like projections, or I call it like the shag carpet, and what that does is just significantly increase the surface area of the lining of the small intestine, and then that aids in digestion and absorption. And if people have gluten, and there's a lot of autoimmune disorder where there's a lot of inflammation here, these villi shorten way down and become very flattened. I've heard some people have described it as like a caked mud appearance instead of a shag carpet. And then you don't have all the enzymes. Not only do you not have the surface area, but then you don't have the enzymes as well to aid into the digestion. So this is actually a picture that I took from that was a PillCam picture, and this is just a great picture of the duodenum, and you can see all these little villi here, and then also off the villi that you can't see are called microvilli to further increase the surface area. And this is the celiac disease, so this is the caked mud appearance where it's just flattened and you don't see all those villi, and then so you don't get good digestion and absorption. Gluten-free diet used to be the hardest diet that I would tell people to take. I mean, it's way worse than a low cholesterol, diabetic diet. It's a tough one. It's getting a lot easier now. 25 years ago, a lot of the foods weren't labeled if they were gluten or not. But now there's basically a big industry in gluten-free, and a lot of people with celiac and without celiac disease are buying gluten-free. So again, that's the essential part in managing celiac disease. It's usually very helpful to have the dietitians involved too, just because of all the foods that gluten is in. It's a tough diet. So in addition to wheat, other grains are barley, bulgur, durum. Some of these are harder to avoid than others. Malt is hard to avoid in Wisconsin. Rye. Ones that don't cause problems and are allowed are buckwheat, corn. So again, with some of the menu choices that we had tonight. And again, I talked about how the oats, for most people, are fine, but they can sometimes be contaminated. Fresh meats, fish, poultry that aren't breaded or batter coated are fine. Potatoes, vegetables, most dairy, wine, and some distilled liquors. I think rum. I don't think is available. Or I think has gluten, but some of the other distilled liquors. And again, it can cause problems with not only the things that we mentioned before, but also vitamin deficiencies, calcium, and some trace mineral deficiencies. And then there's another class of foods that actually was on the menu here too, and that was a low FOD. Those were called FODMAPs in the diet, and those were kind of have been discovered over the last 15 years or so. There's a physician in Australia that kind of pioneered it and showed some good studies that in people who have irritable bowel syndrome, that about half the time, if people go on a low FODMAP diet, that it's helpful. And FODMAPs are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Yes. So the oligosaccharides, those are in the FODMAP diet. A low FODMAP diet often does have a lot of has some cross reaction with the low gluten, although it's not exactly the same, and the dietitians kind of help sort that through a little bit. So the oligosaccharides containing foods are wheat, beans, and then some food additives. Disaccharides are primarily the lactose in milk. Monosaccharides, primarily fructose, and fructose is an additive, a sweetener that's added to a lot of different things. Polyols are alcohols, sugar alcohols. So peaches, plums, mushrooms, cauliflower have them. And disaccharides, again, is mainly lactose in milk. So what the FODMAPs do is you don't digest them well, and so what happens is they don't get digested, they go down into the colon where they have osmotic effects. They draw in more fluid, and that increases the transit time through the stool there, or through the colon. Even though you can't digest them, the bacteria that are in your colon are very happy to do so, and they produce gas and what are called short chain fatty acids, and then those also increase the osmotic load or help the solute in there, so there's more fluid, lower pH, more stool, and again, it increases the stool, and so you get pain, gas, bloating, and altered bowel movements. Then moving on to fiber, we don't get enough of it. So most Americans only eat about 10 to 13 grams, and it's recommended that women should have at least 21 to 25, and men 30 to 38. So again, just a few lists of some foods that are high fiber, and I was really happy to see this because I love raspberries. So again, I think you all have those lists. And those are pretty common to know, the high fiber foods. So high fiber is good for us. What it does, we don't get enough. And so in Western countries, more developed countries that don't have the fiber, we have a lot of diverticulosis. And what that is that's little pockets that are off the colon. And they tend to form in the lower part of the colon, and they can extend either all the way to the top, or frequently they kind of come up and just kind of stop here and don't extend to the top. And so this is on cross-section what they look like. And they're just a little bulge or pocket off the colon. And having the pockets is called diverticulosis, and that is very common as well. I probably see that over half the time in people. Occasionally, a pocket can become infected, and then that would be called diverticulitis. The itis means an infection. Occasionally, pockets can bleed as well. But they're very common and mostly asymptomatic. So this is a barium enema of a colon that has the pockets, the diverticulosis, so they're there at the arrows where they just kind of are bulges out. And then this is a colonoscopy that shows those pockets from the inside and what they look like. Sometimes it can be real numerous, and you can kind of have a hard time telling which is the pocket and which is the lumen that I need to go up to the top. So moving on, this is a baby, and when babies are born, they're sterile, and so they're not only is their gut sterile, but the outside is sterile. When they're born, they receive a lot of bacteria on the transit out, and they are coated then in bacteria, and for the rest of our life, we are coated in what's called a microbiome, or we have a microbiome. And actually we have 10 trillion cells on average in our body. We have 100 trillion bacteria. So we're in the minority. And this just depicts, depending upon what surface you're at, there are different bacteria that tend to be more common. And just a whole range of different bacteria, again, in different frequencies at different places. So normally the bacteria, most of the time, we get along with well, and either they're helpful to us or not hurtful, but sometimes they can become hurtful. And this talks about how in dysentery and diarrhea, there's Chinese 1,200 years ago, well, no, this was in the 4th century, in Chinese medical literature, they talk about treating food poisoning and severe diarrhea with fecal matter. And hopefully everybody's done eating. So 1,200 years later, a Chinese man used yellow soup or the golden syrup. Watch out for that on your menu. And it contained fresh, dry, or fermented stool. And it was drank by the patient. And if you're a Bedouin and you have camels, that fresh, warm camel feces have been recommended as well. And it was effective. German soldiers apparently took it as well. So anyway, C. difficile I think is something that probably most people, most or everybody has heard of. And that is a bacterial infection that's fairly frequent, and it generally occurs in people who've had antibiotics or who have been in the hospital or nursing homes or a healthcare situation. And normally the good bacteria that we have in our colon suppress the bad bacteria. Just like if you have a nice green lawn, you don't have many weeds, but if you get rid of the grass, then weeds can grow, and if there's no bacteria to suppress the C. difficile, it can take over. So using fecal transplant was first done here in 1958. But it wasn't, and it was effective, but it wasn't very popular. So this is what the normal colon looks like, and it's just nice and pale. You can see nice blood vessels through it. This is a photograph of someone who has C. difficile colitis, and it can be pretty devastating. It can be it can kill people. It can be a major problem. So what I've done, there's a company called Open Biome that's out of Boston, and instead of asking if someone has C. difficile, we usually will treat with antibiotics. But it can come back after antibiotics, and it can be difficult to eradicate. And so people are using the fecal transplants now to get rid of the C. difficile colitis. In the area here, it's not done too much, and people were generally having friends, relatives donate their stool. There's a company out of Boston that's called Open Biome, and it was developed by some friends who there was someone in Boston area, northeast area, that had this C. difficile colitis for over a year and had recurrences, and then got a fecal transplant. And so this is a really great company. It's a nonprofit. They have their stool collector, their stool donors, a lot of them are MIT students, and what they do is they test the people before the collection, during the collection, and after. They don't let the stool out until the person has followed up another collection to make sure there's no infectious diseases in there that we can see. And so I've done, I think, 8 of these. What we do is we order the stool. It comes frozen in a 250 cc jug. We thaw it, we do a colonoscopy, we instill it just coming out all throughout the colon. And like I said, I think I've done 8. I've had follow-up on 7, and the 7, all of them were cured and haven't had a recurrence. And there was one person that spends their time back and forth between Kentucky and here, and so I've lost her to follow-up. I don't know if I haven't heard back from her. the future on that is the same company now is developing capsules with the stool in them. And so it's not, at this point, it's not quite as effective as instilling during colonoscopy, but it's an option for some people, especially if they're sick as well and maybe can't tolerate a colonoscopy. Let's see. So there's a lot of interest in the fecal transplant in terms of not just treating C. difficile colitis, but it may the bacteria that we have in our gut affect us and affect our immune system and affect our metabolism. And so there was actually one report of a woman that got a fecal transplant, was normal weight, got transplanted from a family member who was overweight, and then gained weight afterwards. And so people are investigating that, and it's a real, the microbiome is just a place of explosive interest and research now, and we're getting from bacteria that we're still trying to characterize which ones are good. Are we going to be able to, say, use fecal transplants to cure inflammatory bowel disease? People are looking at that. Other rheumatologic disorders, weight loss. There's a lot of different investigations that are going on now. It's a pretty exciting time, and this Open Biome company is really supportive of physicians doing research on these different topics. And right now we're going from bacteria to just at where we were with bacteria about 10 years ago is where we are now with viruses. So now we're talking about the virome of the body, and that is very complex as well, and it's just being started to be looked at. So another thing that I do a lot of is I do a lot of colonoscopies for screening for polyps, and this is a picture of a colon polyp. And there's a snare that's just going around there, and what you can do is just put that snare around the base of that polyp and cut it off and take it out, and that I'm sure is an adenomatous polyp by looking at it. So we do a lot of screening. Why do we screen? A lot of cancers, when we screen, we screen for cancer, and that's what we're doing. So when we screen for breast cancer, we're looking for breast cancer. When we screen for prostate cancer, we're screening for prostate. Colon cancer is different. Colon cancer, hopefully we're not going to find anything, but if we find anything, we're going to find polyps, and we're going to take the polyps out. If we take out those polyps, then we can significantly decrease the chance of having colon cancer. Most colon cancer starts out in what are initially benign polyps. And so this is one that didn't get removed, and so this is a polyp then that has degenerated into a cancer. And this just kind of shows the different stages of, a lot of times people ask, what's the stage of the colon cancer? Well, this is the staging. So if it's just maintained on the inside, it's a 0. If it just goes through into the submucosa, then it's a 1, farther 2, 3 is through the wall, and 4 is if it's spread to other lymph nodes or organs. So colon cancer is the second leading cause of cancer death in the United States. 140,000 Americans are diagnosed with it, and more than 50,000 people die each year. And so that's, again, the importance of screening. March is Colon Cancer Awareness Month, and just a quick plug for our clinic sponsors the Bottoms Up Bash Party, which is coming the first Friday in March. And is it our 3rd year or 4th year? 4th year? 4th year. And so it's fun. We have Matt Gray Band, which is a band that's based in Nashville, and we have them come up, and they came last year, they're coming back again. So that's just a little plug for our Bottoms Up Bash. That's all. Okay. Yes. Yep, here.
A friend of mine couldn't come because she has a cold, and she's had cancer, colon cancer, and something she wanted me to ask about probiotics. Live taking those, that's important to, so she won't have a reoccurrence. And
Yeah, I'm not aware of any studies that show a decrease in cancer recurrence rates or even polyp occurrence rates with probiotics. Yes.
How often is a colonoscopy recommended?
Sure. If people have no family history and they don't have a disease that would give them an increased risk, so no family history, no personal history, no increased risk, it's recommended every 10 years. Yeah, 15 every 10. Yes?
We had one question. If you have polyps that are found and they're not cancerous and you don't have them removed, could they
Sure.
become?
Sure. Yeah, so non-cancerous polyps, that just means there's not a cancer in the polyp. So that means it's a benign polyp. There are different types of benign polyps. So there are what are called hyperplastic polyps, and a couple others that are fairly rare that don't have a significant chance for turning into a cancer. Other types of polyps, the adenomatous polyps, those are the ones that they're benign, but those are the ones that could turn into a cancer. So when we find adenomatous polyps, then those should always be taken out, and that's when we follow people a little bit closer. You can't always tell what a polyp, the type of polyp it is by looking at it. So in general, I think any polyp should be taken out to find out what type it was, and then determine whether there's any follow-up or what follow-up would be needed. Yes?
On TV, they got those advertisements for IBS with diarrhea, IBS with constipation. What are those? And then they have, you could get deaf, I'm thinking, oh.
Yeah, there are a lot of, IBS is a very common problem. I mean, that's a big part of my practice as well. And so there are a lot of medicines that are out there. There are some newer medicines out there that can be helpful. Newer medicines generally mean expensive medicines. So there are some new ones out there that are very helpful for a select number of people. I think the vast majority of people with irritable bowel can be treated with diet, with some simple things, and don't require some of the newer medicines, but they are very helpful in a select number of people. So I do use them, but not first line, not when someone just walks in the door. Again, most of the time people don't need them, and they're pretty expensive. And they can be helpful, but a lot of them are just kind of marginally helpful as well. So there's a lot more work to be done. I think the diet interaction is pretty exciting, and I think that if that can be done, if diet can be done, that's a whole lot better than taking a medicine. Yes?
can you touch a moment on Barrett's?
Sure. What Barrett's is that in people who have acid refluxing up into the lower part of the esophagus, if that's significant over time, then that irritation can cause a change in the cells that line the esophagus. So they have a different shape, they have a different color. Normally the esophagus cells are the same type of cells that we have on our skin. They're kind of flattened pancake. The cells in the stomach are more cuboidal, rectangular. And so what you see is that inflammation, that acid irritation, causes a change in the shape of the cells, how they look, That change is called Barrett's. People who have that are important to find because over their lifetime they are at still a low, but a significant increased risk of cancer compared to people that don't have Barrett's. So it is something that we look at periodically. Generally, what's recommended is if someone has Barrett's and there's no precancer changes in it, that we would look again in 1 year, repeat biopsies, and then usually every 3 years and look at for any precancer changes. If people do have precancer changes, then that's called dysplasia. Then actually that can be ablated, and actually a hospital here, we just got the equipment to do that, where you pass down a tube that is able to deliver a radio frequency wave to ablate it, and it just burns it basically and gets rid of it. We don't generally do it for, unless there's any precancer changes or dysplasia, most of the time. Yes?
What is ulcerative colitis and
Sure.
what causes it?
Yeah. Ulcerative colitis is it's an autoimmune disorder. So it's where the immune system gets confused, and it attacks in ulcerative colitis, it attacks the colon. You can think of it just like rheumatoid arthritis, where in rheumatoid arthritis, the immune system gets confused and attacks the joints. Likewise, ulcerative colitis, it gets confused and attacks the bowel. Exactly why that is, it isn't known. It's been looked at. A lot of different infections and different things have been looked for, and it may be that it's not the same thing for everyone. It takes a certain immune system that a person has, a certain type of immune system with some interaction with something else to trigger it, and then you get the inflammation. So it's a chronic, non-infectious inflammation in the colon. And there are medicines that can be helpful for that. And most of the time it can be controlled. It's like if you can think of rheumatoid arthritis, some people have severe and they have to have they're on strong medicines and gold and get their joints replaced. Other people have most people have intermediate where they maybe need to take an anti-inflammatory pain medicine. There are some people that just pop an aspirin now and then. So ulcerative colitis is the same thing. It can be very severe. It can lead to uncontrolled colitis and needing the colon taken out, to moderate, most of the time need to be on medicines and adjust. And sometimes it's mild, they have one episode and not again, or not for many years. That's pretty rare. Yes?
Tell us a little bit about Crohn's.
Sure, that's the other main form of inflammatory bowel disease. So there are a lot of similarities. There are some differences. Crohn's disease, again, is an autoimmune disorder, but in ulcerative colitis, in the bowel, it just affects the colon. Crohn's disease can affect anywhere from the lips to the anus. And so you can cure ulcerative colitis by taking out the colon. That's a big step, but you can cure it. You can't do that with Crohn's. So there are different medications that are available. We used to use kind of modified aspirin as kind of the mainstay, throw on a steroid if needed. There have been some newer medicines that are a new class of medicines that are called biologics. And what they are is they're immunoglobulins, so they're proteins that our immune system makes, or mice and some of the medicines, and they attack inflammation molecules and bind them and get rid of them that way. So those are biologic agents, and then there are other classes of medicines as well. But it's kind of an exciting time too, because there's some newer medicines that are coming out now, different approaches for Crohn's. That's all I want to say. I know one thing that smoking is good for. I'll say that. One is ulcerative colitis. Actually, when I was in training, we did studies where we used nicotine patches for ulcerative colitis. It can help that. I don't think people should smoke to treat their ulcerative colitis. But the difference with Crohn's is that it actually makes Crohn's worse. So if smoking makes Crohn's worse, it can make ulcerative colitis better. Yes?
There's a lot of talk, of course, about the probiotics and the different kinds of foods and also supplements people can take. What about the prebiotics that they talk more about as far as whether supplements or food or?
Yeah, I mean, it is such an area of ongoing research now. There really at this point aren't very good controlled studies of, double-blind random studies of supplementing people. And so that's the problem is not only there aren't very good studies to support it, a lot of the products aren't standardized, and so you kind of don't know what's in them. So a lot of it is just kind of anecdotal, people saying, I took this and I got better. So, I mean, I think it definitely is an area of interest, of research. I think it's pretty early yet, though, to be able to say, we can't yet say prescribe a bacteria for a problem, but someday we may be doing that. And I think that this open biome, right now it's just a mixture of bacteria that are in people's stools. I think before long it's going to be, and it already is coming, where people are brewing bacteria in vats of, with different bacteria to try to determine which ones are beneficial. And I think in another 10 years, it's going to be completely different. I think, right now everybody says, oh, I do a stool transplant and go, nah. I think in about 10 years, it's going to be the same again. But that's what we have now. So, yes?
How long can a person stay on something like Prilosec? My son-in-law would like to get off of it if he can, but one day and his heartburn is bad.
Yeah, I mean, Prilosec has been around probably about 30 years, something like that. I mean, so there are people out there that have been that long. When those Prilosec is in a class of medicine called the PPIs, or proton pump inhibitors, and they block these pumps in the stomach cells that put out acid. And when they first came out, they were felt to be pretty safe. I mean, there was some concern when I was back in training that there may have been there's some changes in the stomach that were felt to perhaps be a precancer change. You see those changes, but they were felt not to be a precancer change. More recently, there's been some questions about bone thinning, and then also increase in certain types of infections, including C. difficile. So I think that what I do is I treat with what people need to control their symptoms. Years ago, if someone had Barrett's, the thought was they should just be on a PPI and just be on it forever to control the acid, to decrease the risk of cancer. But I think it's important to treat what's needed, to treat with medicines that are needed to control the symptoms well. Because if the symptoms aren't controlled well, then you can have problems from the acid. So there are a lot of people that need to be on, or that need chronic acid, antacid therapy. I don't know if he's done the other lifestyle type things, but I mean, people can do that and still have significant problems. There is actually, in some people, it's appropriate, there's an anti-reflux surgery. So in people who need chronic acid suppression medicines, there's, not everyone, but there are a number of people that we can actually do surgery on. And what's done is the top part of the stomach is wrapped around the lower part of the esophagus, and then that will control the reflux. So surgery is an option in some people if they can't or don't want to take medicine, but it's not appropriate for everybody. Okay, well, thank you all. Appreciate it.